So for our next presentation, I'd like to welcome Jennifer Wright of the Central CCAC, who is the project manager at the Central CCAC since 2003, as well as Debbie Tasic from the CCAC. She's a placement supervisor. And they'll be sharing with us the short stay convalescent care program and RIHC assessment evaluation and demonstrating improved patient outcomes and care transitions. So please welcome our speakers.
So just by a show of hands, how many of you are not familiar with convalescent care? Okay. So during the course of our presentation, we will demonstrate improved patient outcomes and care transitions achieved through the use of RI data. So I would just like to start by providing an overview of the program. CCAC partners with long-term care homes to assess and admit clients to the program. And the program is housed within the long-term care homes, and it is funded by the Ministry of Health and Long-Term Care. In Ontario, there are 690 beds. The Central LHIN houses 105 of those beds. Patients that enter the program require access to 24-hour care, and they do have predetermined rehab goals. There is in-house medical therapy and support services, so PSW, nursing, OT, PT, physician, and in our LHIN in particular, our homes have a designated care coordinator from CCAC that works with the patient team in the home to attend rounds and plan patient care. The maximum length of stay is 90 days, and that's based on attaining the rehab goals. So while the maximum is 90 days, patients are often discharged before that time if they meet their goals and are able to return to a community setting. So what is Central CCAC's role? So we're responsible, and our care coordinators are responsible for assessing applicants and determining eligibility. We complete the RIHC assessment within 24 hours of referral, and that's for our hospital referrals. We prepare for discharge and transition to community. So again, in Central LHIN and Central CCAC, our care coordinators complete a discharge RI, meet with the family and the client to system navigate, coordinate CCAC services, and link to community services as required. So I'm going to introduce you to a patient story. This is Mrs. C. This is one of our patients that were on our program. Mrs. C is 77 years old. She was at home. She lives alone. She's widowed, independent before her fall. So she fractured her knee. Post-fall, she was admitted to the hospital. She required surgery for her fractured knee. On day 7, the hospital sent a referral to the CCAC in hospital to assess the client for convalescent care. And on day 7, the RI was completed and rehab goals were determined. Day 12, the patient was admitted to a convalescent care program. On day 44 and I should just say, prior to when the client was assessed for convalescent care, she was a one-person assist. She was complaining daily of severe pain, and her mood was quite low. So then she was admitted to convalescent care, and on day 44, her rehab goals were met within the home, and a discharge RI and care planning was done with the patient. And on day 49 of her stay in convalescent, she was discharged home, and at that point, she was independent with all ADLs and most IADLs. Her pain was much better managed, and she was independent with her walker and able to climb the stairs. So this slide will make more sense going forward, as Jennifer will present more of the data and the scales pertaining to the RI. But this just shows the admission and the discharge data for the scales, the RI scales, for Mrs. C, and how she improved from admission to discharge. And when you look at the medications, you can see that she was using less pain medication. There was decreased sleeping medication and also blood pressure medication. So some improved outcomes. And also Jennifer, as I said, will now speak to the data.
Thank you. So I'm thinking most of you are familiar with the RI instruments. That's safe to assume. And I will move on. So our data included 1,681 unique patients with a RI home care completed. And I will now begin the RI highlight reel, which will go a little quickly. So demographics, we chose Miss C based on the demographics. As you can see, that 20% lived alone, and 54%, you'll see in a second here, were widowed. And again, the average age was 81. The mode was around 86 for the most frequent age. So I'll just move through here. So these are the not the algorithm, but the scales that we'll review. And I'll explain a little bit each as we go through. So first of all, the chest comparison. The chest ranges from 0 to 5, and the 5 indicates increased medical complexity, increased risk for our mortality. We had overall 68% improvement in the chest score upon the discharge RI. And Miss C, she came in very low. She came in with a 1. She only had a change in her ADL status due to the fracture. Otherwise, she was completely medically stable. And what you can see on here is the majority, try not to click here, the majority are in the stable range on admission. And so that tends to be the candidates that we see. The pain scale is very simple scale, of course. The 3 out of 3 indicates daily severe pain, and that's what Mrs. C had. And on discharge, she actually went down to a 2, which might not seem like a big improvement, but it was daily mild pain. The 2 out of 3 represents mild to moderate daily pain, so it's the frequency, but there can be an improvement with the 2. I mean, a more significant improvement with the 2. So again, you will see that pain management is a critical factor. From the referral source also to the attaining the goals of the pain management's not addressed within the program or even before the program. Okay. So the big success is obviously the ADL. And the ADL, this is the ADL hierarchy scale. So it includes personal hygiene, walking indoors, toileting, and eating. So what you can see here now, when Miss C came in, she had an ADL score of a 4. So she was requiring extensive assistance, full performance with some of her ADLs, with most of her ADLs, even bed mobility. But this actually only considers, in this case, she was personal hygiene. She required help with everything but eating. She was receiving help with. And on discharge, she actually became independent with all 4 of those ADLs. So what you can also see here is that, again, on the range on admission, it's basically looking at 1 person assist is usually some of the criteria. Okay. The ADL long, I like this scale because it includes all the ADLs. And it really showed a huge improvement. Miss C had 18 on admission and improved down to a 2. She was still requiring supervision with bathing and a little bit of help with her shoes. But other than that, she was independent with her ADLs. And you can see again that the range from about 5, it's really the midsection, up to the 20 where on the admission, and 87% of the patients demonstrated improvement with this scale. The MAPLE, which is driven by the ADL hierarchy, of course improved just by that alone, because the ADL hierarchy is within every level of the MAPLE. So the MAPLE ranges from low to very high, and of course is a predictor of long-term care placement, as well as looking at resource utilization for home care services. So the shift, as you're seeing, the shift to the left is indicating now these patients have successfully moved to a lower level of need in the community, back to the community. So you can see here on admission for criteria, moderates came up 73%. And if you combine the high and the moderate, it's basically over 90%. These are the care planning protocols. So these are used by the care coordinators to help assist in validating with the patient how they're going to proceed with the care planning and making sure that anything that comes up here is addressed. So you can see again the rehab algorithm, the ADL rehab potential algorithm, which is really assigned as their motivation as well as their potential for the candidate. So it's definitely an excellent criteria, as again most of the patients in this data review basically triggered that cap. We can also see some other areas, of course, pain, falls, and psychotropic drugs down to depression. With depression, out of note, just because of some earlier sessions that I attended, the depression, the rate of change was actually 43% actually improved on depression, but then there was 40% there was no change. So when they talk about therapy improving mood, there was an improvement, but there was also significant no change. So this I put together just as an idea around looking at the criteria based on the data review. So what did, from the whole data review, people were generally medically stable on admission. This is from the admission score. They definitely had ADL needs requiring one person. And if you're thinking about all the widows and the population that's going into the convalescent care, it'd be very difficult for them to manage in their home, requiring that level of assistance, especially with toileting, dressing, and, or in terms of the hierarchy, just even walking. And of course, the MAPLE was moderate to high, so they're still relatively cognitively intact. And then the motivation was always triggered. So that's just to give an idea of some criteria. And this is going into the outcomes. So this outcome slide is by long-term care home. And this really just shows that they are transitioning. The goal of the program, they can't stay there. They have to go home. So the idea is that this is showing that it is working in terms of they are going home. And this was put together showing some other destinations there, because the home is truly home in the community setting. And so we didn't want to kind of skew that home. Okay. And so the care transitions, we also looked at the referrals to CCAC, and 66% of the patients did not receive central CCAC home care services or long-term care services post the convalescent care program. And 34% did receive some form of services post convalescent care. So in summary, the convalescent care program is a huge success, and one of the reasons why we wanted to present here today, because we haven't really presented on this data before, and in terms of conferences, and there's such significant improvements. And then the other areas for greater improvement would be looking at, there's always room for improvement. So even with the falls, yes, they dropped down, but it was still 48%. Is there room for improvement? Of course, with rehab, there's always maybe some, there's always potential risk, but there's improvement for pain, of course, falls, looking at the continence care, and also looking at depression, and also validating the falls coding. We want to do some further validation to make sure that the care coordinators are actually coding since the last assessment. So you're supposed to code either a fall within the last 90 days or since the last assessment if completed less than 90 days. So we want to make sure they're actually doing that, because that might make this look like a worse picture than it is. Thank you.
Thank you to all our speakers. At this time, I'd like